Alright, hello everyone. Welcome to the first talk of the spring term. We are really happy to announce Dr Sara Tai, who's going to be coming to talk to us today, as you see on the board, about psychedelics and psychotherapy. So I'm going to hand it over to her now.
Thank you very much, and it's an absolute pleasure to come and speak to you this evening. Can I just check, are you able to hear me at the back okay? Perfect. Okay, so, as Ben said, I'm Sara Tai. I'm a clinical psychologist based over in Manchester. And I'm a practicing clinical psychologist. So for the last 25 plus years, I've been working with people who experience problems that affect their mental health in quite significant ways. So I've worked in community mental health teams, early intervention services for psychosis, and also on acute inpatient units. So my research has predominantly been within the area of psychosis and quite severe mood swings that people can experience. But it's been within the last number of years that I've become much more interested in working with people in altered states, and particularly with psychedelics, which we're going to talk about today. Now, you'll have to forgive me, I am actually visually impaired, particularly in the light. So if I'm talking about something that does not match my slides at all, just give me a wave, because it's a bit hard for me to see them. And hopefully I should be able to know my slides well enough to follow them, but I will have to wear silly glasses at some point as well, just because of the light. So what I was hoping to talk to you tonight was a whole range of things connected to psychedelics. I'm going to talk about mental health and why psychedelics in mental health might be so important. Also about some of the current evidence that we have around psilocybin. And I'm going to talk a little bit about the therapy, so actually doing psychedelic assisted therapy, what that involves. And I know that's quite a lot of stuff to fit in, but I hoped that it would appeal to people who are here just out of interest and want to know a bit of a wider range of what's going on within this field. So do feel free to sort of wave at me and say, can you tell me a bit more about whatever? And of course we'll have time for questions at the end. How does that sound as a plan? Okay, so I'll try and plough through it and not go into too much detail so that you get a bit of an overview of lots of different things rather than me focusing too much on one. So, obviously, and I appreciate that a lot of you, given that this is the Psychedelic Society, you will know a lot about psychedelics, but I also know that there might be some people here who are here out of interest and won't know so much, so I've included a definition of what we're talking about as well. So psilocybin is, of course, one of a group of substances known as the classic psychedelics, and others include things like mescaline, LSD, DMT, which are all substances that can have quite a profound effect on our thinking and how we process emotion as well. And psilocybin is found in well over 100 different types of mushroom. So it's that ingredient that's, that key ingredient in so-called magic mushrooms. And when they are ingested, psilocybin is converted into psilocin. Now, some people call it psilocin. I think it's just a pronunciation thing. I call it psilocin. And what it does is that it acts on neurotransmitters in the brain known as serotonin. Okay, now psilocin isn't a form of serotonin. It imitates the action of serotonin, so it acts as a partial agonist. And we think that it might also have some indirect effects on other neurotransmitters as well, such as dopamine. But the effects that this compound has varies quite significantly from different, from individual to individual. So if we all took some right now, I'm sorry I don't have any samples so we can't, and I would get arrested, but if we were all to take it this evening, we would have quite different experiences and effects. Okay, and that's quite an important thing to remember. So the way in which it has an indirect effect on other neurotransmitters is not particularly well understood at the moment. So we are quite early on in our understanding of how this actually takes effect It's all quite experimental. But what we do know is that psilocin induces quite an unusual experience, depending on the dose, and an unusual state of consciousness. And with that, people experience quite profound shifts in emotion and also the way in which they perceive things and are able to cognitively process information. And believe me, it can be quite intense for some people. So just a bit about mental health to begin with, and why are we even bothering to look at the application of psilocybin within mental health issues? Well, for a start, around 1 in 4 people will suffer from a mental health issue at some point in their life, and that's a lot of us. And 75% of people will, if they're going to have a mental health issue, will often experience this by the time they are around the age of 18. So signs of it often start quite early, and it goes unnoticed or undetected until much later. And of course, of those people who are experiencing mental health issues, around 70 to 75% of them will not actually end up having access to treatment, which is quite surprising, but that's how it is at the moment in this country, partly because services can be difficult to access. People, it goes unnoticed for a lot of people, or people try and access treatments, but the side effects or the utility of that treatment for them isn't particularly good. And I don't think the range of treatments we have available to us at the moment in psychiatry is necessarily that broad or useful for many people. So of course, mental health issues are the single largest cause of disability within this country. And they actually contribute 22.8% of the total burden of health issues within the UK. Again, just to give you an idea of the impact of mental health, we're talking about 72 million days per year lost, which costs the UK 34.9 billion. And of course, it contributes, so the total cost of mental health altogether in this country is around 105 billion per year. Now that's a huge amount of money, isn't it? And I'm not making this point because I'm saying, we shouldn't be investing a lot of money in mental health. I'm saying if that's what it's costing us so far, the good that we're doing people and the treatments available, it's a bit poor, I have to say, given the amount of money involved. Well, I've already answered this question, haven't I? But don't we already have effective treatments, is what people often say. And I'm afraid, unfortunately, no, that's not really the case. Our treatments are not that great. Please don't hear me as saying that, lots of people aren't helped in some way by services. What I'm saying is that so many people are let down or not helped in the way in which they need by services currently. So we need to be doing better, is what I'm saying. So the majority of treatments we have on offer in the UK really are around medications, because so many people, they want to have access to psychological interventions, but they are not available to the extent that we need. So the mainstay really is medication. And I'm going to use depression as an example right now, because that's where a lot of the research in psilocybin has been to date as well. Only around 36.8% of patients actually achieve remission on selective serotonin reuptake inhibitors. And for those who were in remission, or for those that demonstrated remission after SSRIs, it was between 5.4 and 7.4 weeks after administration. So basically, the evidence that we have for antidepressants is always around the 3-month mark. And positive effects are found at that point. The worrying thing is that the longer people are on antidepressants, the less effective those antidepressants seem to be. Okay, so people talk about them being really effective, but only at the 3-month mark. And therein lies the problem. So after this, like I said, the results tail off, but also there are so many aversive side effects that make most of the people who take them find them either unacceptable or, they struggle on with them, not really getting the result that they want. And common side effects include things like, pretty unpleasant sexual dysfunction or reduction in sex drive, headaches, apathy, dizziness. There are some studies that have looked, meta-analyses of a whole load of trials reporting that they actually increase the risk of serious and non-serious adverse events. And I'm only talking about antidepressants here. If we start to look further afield across mental health altogether, and I switch to talking about neuroleptics, people are often prescribed for psychosis, the picture certainly isn't better. In fact, it gets worse. And the serious side effects from neuroleptics are utterly awful. So a whole range of problematic effects have been documented, including problems with dependency, and there's been lots of difficulties with the Royal College of Psychiatrists saying, no, there's no problems with dependency, and then changing their minds and saying, well, actually, this isn't looking too good, we need to consider broader treatment options. So the take-home message so far is it's not looking that great in terms of treatment options, and the side effects have been pretty poor for people. This is just a meta-analysis that was done a number of years ago, about 5 years ago, of 38 studies involving 2,099 patients, and they found that literally only about a third of people really benefited from those antidepressants at the 3-month mark, remember, and 10% of them deteriorated despite receiving treatment. Now, for those of you who might not be aware of what we mean when we talk about effect sizes, we're really talking about the number of people we need to treat before we have any positive effect, and it's measured usually by hedges, etc., and 0.2 is the lower end of what is considered a good effect size. It's pretty poor. Above 0.5 is considered much better. So the effect size for our current treatments, very low, not great at all. And it's not much better in terms of psychological interventions for ongoing depression. Effect sizes are fairly small. So we have a long way to go. We have been desperately needing something new for many years, and what we're hoping is that the psychedelics may offer some new opportunities. Now, the other thing about antidepressants and other psychiatric medications is the way in which they work. And by the way, nobody's really that sure why they work. People have often talked about them acting on things like serotonin and neuroleptics acting on dopamine, and talking about correcting some form of chemical imbalance. Well, again, I'm sorry to break it to you, but that theory is the biggest load of baloney that we've probably been told this century. There is no such thing as the correct amount of serotonin or other chemicals in the brain. In fact, the place where there is the most serotonin in the body is in the gut. And how much is the right level, nobody knows. It varies from person to person. And so how these medications actually cause any benefit or create any benefit, we're not really entirely sure. And I'm sure there'll be many psychiatrists who would love to argue with me on this point, but I'm just telling it as the evidence suggests at the moment. And so what these medications seem to do is dampen down emotion and make our processing of information such that the salience of information around us is dampened down. And if you're in a heightened state of distress, that can be very helpful. To just put a bit of a blanket over the fire of distress, for want of a better analogy, can be really useful in the short term. But as a long-term strategy, for resolving mental health issues, I wouldn't really recommend it for my family members, put it that way. So, it potentially reduces the intensity of emotion by dampening down awareness. And yet, perhaps what we need to be doing is helping people understand their problems in ways that are more detailed so they can start to find solutions. So what I'm saying that we should be doing is increasing people's awareness. So we've got a little bit of a discrepancy here as to what we think might be beneficial, but the way in which medications act. And here's where psychedelics may offer something new, because instead of dampening down awareness, they're all about opening up people's awareness to being able to look at things from different viewpoints. So it's a very different mechanism of action. So what is the mechanism of action then of psilocybin in particular, or psychedelics? Well, they're thought to actually affect cognitive and emotional patterns by down-regulating what has been hypothesized as the default mode network, and you may have heard that term branded around in trials. Now, like I said, this is not a definite thing that anybody's observed. This is what, when you put somebody in an fMRI scanner and you're looking at the brain activity, you see changes happening in the brain, particularly in the areas where we know cognitive and emotional processing is happening in relation to our sense of self. Now, what do I mean by that? We have patterns of thinking and feeling that are quite unique to ourselves, but nonetheless it's the way in which we manage our emotions and thinking on a daily basis. So when you put somebody in a scanner and you get them just to rest, you see quite unique patterns at resting state. And these patterns reflect the way in which we think about things. They're influenced by our previous experiences, memories, perceptions, and it contributes to the way in which we understand ourselves as human beings. That's what I mean when I talk about our sense of self. And of course, the default mode network are, those patterns and how they're represented neurocognitively in the brain as well. So you could sort of see patterns within scanners of that happening. I'm sorry, that was quite a that was a fairly dumbed down, crude explanation of the default mode network. It does get a bit more complex, but I could give a whole talk on that, but we don't have time. So I hope that was a fairly succinct sort of explanation of what we're talking about. So psilocybin is not switching this off or anything, it's down-regulating it. So it basically means it's turning the volume down rather than changing it or switching it off. And it's doing it temporarily, so it's a transient state. Now, because of this, those usual patterns that we have of processing information and managing things, because they get turned down, it means that our brain's open to being more flexible. That's what we think is happening. And so experiences become much more pliable. We have the potential in that state to process experiences in a very different way to what we normally do. So we're not correcting anything, we're not making permanent changes in the brain, we're turning the volume down so that we can be open to experiences in a different way to usual. And again, the degree to which that happens will vary quite considerably from individual to individual. Does that make sense? Yeah? So the default mode network, because, like I said, it's this pattern of responding, if, for example, you're somebody who, maybe you've experienced in life a lot of trauma, you may well be quite geared up to spot threats much more than people who have not experienced trauma. You may well worry a lot more about certain things. You may read into things in ways that people who've had different experiences don't do. That's not to say that the way you think is abnormal. There's nothing abnormal about that. It's just neurodiversity. It's just a different way of engaging with information and the world around you. But it does mean that you may be geared up to look at things in ways that might not always be helpful in every situation. Okay, so if you're not in a threat situation, it's less helpful. And of course, if we can down-regulate your default mode network, you're kind of down-regulating the extent to which you apply those usual response strategies. So you might not worry so much, or you might not ruminate or look at threat in the same way. And of course, again, that opens us up to being able to experience things in a different way to usual. And that's the important thing here. By temporarily down-regulating what is actually a control strategy, we have experiences that then take on new meaning. We have something that we've never experienced before. And that can offer quite considerable opportunity for new insights and new ways of thinking about things. That is the mechanism of action that I'm proposing psychedelics may well have. So in this sense, you can think of it as a form of exposure. Okay, you're exposing yourself to experiences in a way that you wouldn't normally be able to engage in those experiences. So it's quite an important process in mental health. So instead of disengaging and moving away from experiences, you can engage with them and learn something new. This, we hope, brings new perspectives and insights and a whole new way to finding solutions to current problems. This explanation that I'm giving as the mechanism of action fits very closely with qualitative information we have from people who take psychedelics. And it also is entirely compatible with more neurocognitive theories that psilocybin promotes neuroplasticity. Well, yes, not because it's directly changing the brain permanently, but it alters the brain state enough to create new experiences which will be able to change the brain at new pathways. So again, this is consistent with a more biological and psychological understanding and explanation. Now, the good news is when we have been delivering psilocybin to people, the other thing, unlike many of the other antidepressants and neuroleptics that we use within psychiatry, there have been no serious adverse events reported in contemporary trials. Now, back in the 1950s and 60s, when so much research with psychedelics was going on, they weren't very robust in terms of their design, so they haven't really taught us much scientifically about how it works, but they were brilliant for demonstrating that in thousands of administrations, nobody had any horrible physiological reactions. So this is very low toxicity and relatively safe physically to take. Now, whether it's psychologically safe, I'll come on to that in a moment, but physiologically, loads of studies in contemporary science to suggest that's fine. And of course, we conducted one very recently, funded by Compass Pathways PLC. And we did this study on around 80 healthy volunteers, and we looked at cognitive and emotional processing, and we found that there were no detrimental effects on that, and no physiological adverse reactions. So again, very safe. And that's the largest study of administration on healthy volunteers. So moving on to think then, if it's pretty safe to take this physiologically, what evidence do we have so far that it may be helpful within mental health? Now, there haven't actually been that many trials published. So what we've got is a total of 9, plus I'm going to talk to you about the study that we've just completed, again funded by Compass Pathways, and that's the largest trial of psilocybin for depression ever conducted in the world. I'll get onto that in a second, but just to give you a little look at this, obsessive compulsive disorder, I won't get on my rant about diagnostic categories and how valid they are. That would take a whole evening, so I'll step away from that for the time being. But I just want to make the point that, viewing diagnostic categories as real illnesses, there's a whole range of problems with that. So, for people who meet diagnostic criteria for obsessive compulsive disorder, again, there was only 9 people in that study. There have been a number of studies looking at cancer-related distress. And by distress, I mean anxiety and depression. This one by Grove et al., that's a US study, only 12, but very good, promising results, as promising as you can have with only 12 people. Johnson et al., they looked at tobacco smoking and they had a pretty good result. 80% of their participants were not smoking at 6-month follow-up. Some on alcohol dependency, but then the rest has all been on depression, either in cancer or pretty much treatment, what's called treatment-resistant depression. So this is where people have not had any benefit, mostly from medication, basically. And again, the largest of those studies is Robin Cartwright-Harris's, which is the most recent one they did, where they compared people who took, they gave some people psilocybin, 2 doses of psilocybin, I think 1 milligram and then a 25 milligram, and they gave them a placebo, so not an antidepressant, and then they had a second group who had a 1 milligram psilocybin, and they had escitalopram, which is an SSRI. And they found that there were no real significant differences between the groups. But, can I just say, at 59, that study was never powered, so it was never, they never had the number of people to be able to demonstrate superiority of either of those treatments. It was just a feasibility study. So it wasn't that this didn't produce any significant results, it never intended to. It just wanted to see whether it was safe and also feasible for people to be able to engage in this and also estimate the likely effect size. But they didn't find any significant differences. They did have some quite promising results on their secondary outcome measures, and they looked at things like well-being rather than depression symptoms. But again, that was not significant. So that's the largest trial. But overall, some of the effect sizes, and remember I was saying that for medication it was around 0.2. Here you're talking about 0.5, and many of them are up to 0.8 effect size. That's a huge amount more than we're seeing in medication. Now the problem here is that where studies have small numbers, effect sizes are always inflated. So you need to have much bigger numbers of people to see whether that result is real. So what I'm saying is there really hasn't been many, there haven't been many trials to date, but all of the trials are looking very promising. But I'm quite cautious, for the reasons that I've just said. We need a lot more research in order to be able to show whether this is going to be effective. And again, on a side note here, unfortunately in the UK, we still have psilocybin on what's called a Schedule 1 license. So that means to do this research, I have to go to the Home Office, get a special license to be able to store the drug. It's a complete pain in the backside. It takes a long time to get that license, huge amounts of paperwork. This is a major block to us getting research done in the UK. In the US and other countries, they are allowing people to do research much more easily, so they're going to be streets ahead of us, and we're really being held back here because we can't do the research. So, we have been campaigning to the government for quite some time now to try and reschedule for research purposes, but we have not had much luck yet. Now, of these studies, 4 of them were included in a meta-analysis by Goldberg et al. In 2020 they published this, and what they found on that meta-analysis, so this is where you get together a whole load of trials and you reanalyze the data together to see whether it's, whether the effect sizes are any good. And on the basis of those 4 trials, looking at symptoms of anxiety and depression, again, they found that the effect size was between 0.82 and 83. That's fantastic. This is like, whoa, this is a dream come true. But, like I said, let's be cautious and see what's happening. So let me tell you then about the COMPASS trial. This is a trial where we recruited around, 234 people, I think, all diagnosed with treatment-resistant depression. So they had to have had at least 2 antidepressants and failed on those in order to come into this trial. And the reason being is that they say, well, hang on a minute, in this country, the NICE guidance says that the first line of treatment should be antidepressants, so you've got to give people that, and we're only going to let you give them an experimental drug if they've already tried the first line treatment. That's why we had to target people who had already tried something else. So they may be people, because they've already had a sort of failure experience, it might be that they are less likely to want to engage in treatment. Possibly. I'm just saying that there are some caveats. This group is not necessarily representative of everybody with depression in this country. This was a randomised, controlled, double-blind psilocybin therapy, treatment-resistant depression. This trial started, the planning for this trial started about 5 or 6 years ago. My role on this trial was to basically author the psychological therapy. So we cannot give psilocybin therapy without having psychological therapy alongside it. It may actually be harmful. And so my role was to say, right, what on earth are we going to do? Now, luckily for the last 15 to 20 years, my research has been looking at what is it we think is effective in psychological therapy. What's the thing across, if we took 20 odd different therapies, and by the way, there's estimated to be between 250 and 1,000 different types of psychological therapy out there. What we do not need is another psychological therapy. So my work has been looking at what seems to be the common ingredient across all of those therapies. Because if there's something that all of those therapies have in common that seems to be working, let's focus on doing that. And so my approach to therapy for this trial is based on that work and capitalising on what it was we think was helpful. Here's what the trial looked like. So, 234 people recruited. 79 people given, so they were randomised, they were blind, nobody had any idea what they were getting, and we didn't know who was in which group either. So that's what we mean by double blind. 1 milligram of psilocybin, 10 milligrams of psilocybin, 25 milligrams of psilocybin. So everybody would come in, be screened, they would have to withdraw from their antidepressant to be included. We gave them 3 sessions of what we call preparation therapy. This is just explaining to people what to expect, making sure that they were ready for the therapy, that they had a relationship with the therapist that was based on fairly good rapport. And then they filled in their measures at baseline. They were then administered a dose of psilocybin. That's day 1. And then the day after, they received their first therapy session. This is talking therapy, and we called that integration. Then each week after, they received another therapy session, and then at week 12, so these are 3 therapy visits here, and then at week 12, they had a follow-up just for safety, and we monitored them throughout the whole trial. The primary endpoint, so the key thing we wanted to look at in terms of outcome, was the Montgomery-Åsberg Depression Rating Scale. This is a measure of depressive symptoms, and it's clinician rated. It's not self-reported. So clinicians would interview patients and rate how depressed they thought those people were. and the raters were independent, so they were blind to the condition and they didn't know who was who, so it was a more independent measurement of depression. So let's have a look then at the results of what happened on those depression measures. So here you can see day 1, that was the day that people, that was baseline, and day 2, day 1 is when they actually had the psilocybin, day 2 is the day after. But we took their baseline measures of depression. And you can see that for the 25 milligram group, which is in blue, a massive reduction, and the 10 milligram is green, the grey is the 1 milligram. So everybody got better, became less depressed. And of course, if you think of the 1 milligram as being a placebo, you could say everybody had a placebo response. But clearly the 25 milligram group was doing better than anybody else, which is the result that we kind of wanted. And then you see depression symptoms go up again, but not back to the way they were. That does call into question, well, why did that happen then for the 1 milligram group, where we don't expect 1 milligram to induce an unusual state or do very much? That was considered the kind of control, not a placebo because they're getting something, but it wasn't expected to do very much. Let's look at what's called responders. Now, a responder is defined as somebody having more than a 50% decrease in their depression symptoms from baseline. And as you see, at different points in this trial, it's the 25 milligram group that seems to respond much more than any other group. So there's a statistical significant difference between the 25 milligram group and the 1 milligram group, not necessarily with the 10 milligram. But 25 milligrams seems to be the optimum dose. So results looking pretty darn good. This is a graph showing what we call remitters, and they're defined as people who have a score of depression that goes to below 10. So above 10, if you consider that as a caseness for depression, people who have dropped below that level in each group. And again, you can see that for the 25 milligram group, there are far more people who are showing a greater reduction in depression, and it is sustained at the 12-week point. But that's still only 3 months, similar to antidepressants. Okay? So what we need here are longer-term follow-ups, which Compass will be doing, but those results obviously won't be available for some time yet. I think I've pretty much said it, but there's a slide just summarising the results that I've just been through. The Compass results are available online as well through the Compass Pathways website. You'll see these slides there. Now, I mentioned earlier that we had to take people off their antidepressant medication to be in this trial. Since this trial was conducted, Compass have also done another subgroup where they, with 19 people, administered psilocybin therapy to people who did not come off their antidepressant medication. And what they found is it seemed quite safe to do this. When you looked at the depression scores again, they did all the same checks as we did in the trial, and there seems to be quite similar results. The good news, therefore, is that for people experiencing depression, because coming off antidepressants is no fun business, and it is quite problematic for a lot of people. So to be able to deliver psilocybin-assisted therapy without taking people off antidepressants would be a complete turnaround. It would be amazing for us to do that. And what this study shows is that there doesn't look to be any reason why we can't do that. I think for me we would have to check people more closely during dosing, because there is a risk of something called serotonin syndrome, just because of the increase in serotonin that may occur. But it's all looking good. Okay, so very quickly then, let's have a think about the therapy in psilocybin assisted therapy. It usually occurs in 3 phases. As I said, preparation. That's really about getting to know your therapist and having a good relationship with them. We know that if you're with somebody that you don't trust and you can't really talk openly with that person, chances are it's not going to be very helpful. And lots of research shows that. The research that I've done at Manchester with my research group, again, what we have found is what's helpful about therapy is the degree to which somebody is able to focus on emotions, but be able to talk openly about that without filtering what they're saying. Okay, so it's not necessarily just the therapeutic relationship that's important. It's the degree to which that therapist is able to help that person feel comfortable talking honestly and not filtering things. That's the key. So preparation is really important for making that happen, and also getting people to a point where they are open to being able to sit with whatever experience comes up. It's that open-mindedness and curiosity that's absolutely vital. We then do the dosing, and it's a full day. I try and dose people as early as possible in the day, like as soon as the pharmacy can get this over to us, because the effects of psilocybin should be in the region of around 6 hours, but for some people it can be much longer. And I've noticed anecdotally, I can't say this is absolute, but it's the slight people, quite often females, the ones who are lower in body weight, who tend to have an experience that goes on a little bit longer. So the dosing day really is a full day. People lie down on a bed, we put eye shades on them, they have headphones on and listen to music for the full day if possible. And we're encouraging people to really engage with whatever experience comes up. Now that can be quite challenging for some people. It might be that a load of memories from the past come up. Not necessarily bad memories, but memories that just bring up a lot of emotion. And even if it's pleasant emotion, emotions can be intense. And that's difficult for us. We're not used to experiencing our emotions so intensely for the whole of one day. And that's what I mean by challenging. Many people find it amazing. They're in complete ecstasy, but also the experience waxes and wanes throughout the day. And some people, it's so intense, it's a bit overwhelming. So our job as a therapist is to sit with people all day and be very attentive to what's going on. They usually don't want to speak. Okay, they don't lose the power of speech, but people choose not to talk when they're really in the throes of the psilocybin experience. And so our job as a therapist is to guide them through this and just make sure that they feel comfortable and that they are not experiencing emotions that are so overwhelming that it removes their ability to engage with that and stay with it. And then in integration really is talking therapy, and it's about helping people make sense of their experiences and develop new insights about those experiences and what it might tell them about the problems that they've been experiencing in their lives and their depression. I believe that this process should be very client-led, so participant-led, and it's not about us advising and guiding people into a certain direction. It's about helping people explore, become more aware of why they might have become depressed, and think of a whole range of possible solutions, and then support them in trying some of those out. The problem that we have at the moment in psychedelic-assisted therapies is that there hasn't really been a specific therapy that's been recommended. What has been going on in trials is vastly different. And you go back to the 1950s and 60s and you see what therapy they were doing. It was all sorts of psychoanalytic interventions, more recently CBT, etc. A whole range of different things. So you either have something that's non-specific, so nobody really quite knows what the therapist is doing exactly, or you have therapies that are associated with very specific therapeutic orientations like CBT, cognitive behaviour therapy, motivational enhancement therapy, mindfulness, acceptance and commitment therapy. Those are very much delivering that therapy, but using the psilocybin to assist it. Now, I think there's a bit of a problem with this, because to administer psilocybin without therapy could be psychologically unsafe. You know, people are directionless, don't really know where they're going. Intense experiences can actually have quite harmful impact. So we definitely need something. Without some guidance, intense experiences can lead to quite significant paranoia, fear, anxiety. People talk about bad trips, and that can leave somebody quite traumatised occasionally. So we do need to be careful. And you know, the non-specific therapy could give a message that actually it doesn't matter what you're doing with the therapy, it's actually the drug that's important. And that doesn't seem to be the case based on evidence so far. Also, for people who take psilocybin recreationally, people aren't frequently having spontaneous recovery from their mental health issues. So it does seem to be that that's much more likely to happen within a safe, controlled therapeutic environment. In fact, we actually recommend that people don't try and manage their mental health problems by themselves outside of a supported environment. It's very difficult to control the environment around you, and you know, when your perceptions are all over the place, that can be a very unpleasant place to be. Also, mental health issues are multifaceted, so we need to have a multifaceted approach. The problem with therapy-specific approaches is that you know, our therapies tend to be, you know, therapy for anxiety, or therapy for depression, or therapy for PTSD. And for most people who have mental health issues, there isn't just one problem, there are multiple issues, lots of comorbidity. Many therapeutic approaches don't provide empirical explanations as to what the mechanism of action is and why psilocybin might work. That's been another issue. Also, for lots of different therapies, it doesn't matter which one you have, people tend to report some effect. You know, so again, this is what we call the dodo bird effect, that all therapies tend to end up being quite equal in trial, you know, one's not necessarily superior to another. So if we go down the route of these specific therapies, we'll end up being in a situation where we have to run so many trials with psilocybin to test each therapy as well as psilocybin. I think that's going to be expensive, and again, not necessarily beneficial for the people that we work with. So my role within the psychedelics field, where I've been trying to contribute, is why don't we look at what seems to be the common ingredient across all of these therapies, as I said earlier, and focus on doing that. And that indeed was the manual that I wrote for the Compass trial. And I trained about 150 people in this approach. Not all of those ended up being therapists on the trial because we had the turnover of people. But we had 21 different sites across 10 different countries, and boy did I get sick of travelling and training these people. But it was really interesting, and I got to dose quite a lot of people and deliver therapy with people on psilocybin, so a lot of fun. Now, the approach that I use is based on a theory called perceptual control theory. This theory has been around for a very long time, since the 1950s and 60s, but really only became more commonly known more recently. It was actually developed by Bill Powers, which is the reference there, and myself and some colleagues in Manchester have spent the last 15 to 20 years doing a lot more research on this theory and developing the therapeutic application. Why this theory? To date, it is probably the only functional theory of mental health. And by that, I mean it actually is a theory about how we function that is testable. You know, it directly models human behaviour rather than being based on a hypothetical theory. So it's very amenable to testing, and it's a biopsychosocial framework which is based on homeostatic principles. So if we think about how we regulate body temperature, how we control body temperature, the same principles of that are used to understand mental health. Now, in a nutshell, it would take me quite a lot of time to explain this theory, and you'll be glad to hear I'm not going to try and do that this evening. There's plenty you can go and read. But just in a nutshell, from this perspective, as in perceptual control theory, positive mental health and well-being is about being able to plate spin. Okay, so spinning plates are just right states. And what we say from this theory is that we all have our just right states that we want to maintain. These are psychological, biological, social variables that we want to keep within certain parameters. It might be how hot you like your coffee. Not too hot, not too cold, just right. How close you like to be to other people, particularly in a pandemic. You don't want to be too close, don't want to be too far away. We all have our just right states. Now, distress occurs when our just right state isn't maintained. Okay, so I might have a just right state for how interested I want you to look. Am I doing a good talk? And of course, if you're all looking really, really bored, I'm away from my just right state, and I'm going to do something to try and bring myself closer to you looking more interested. I might wave my hands more, or talk more passionately, or whatever. Now, if I don't get my just right state met, I'm going to be distressed, and I need to be able to be aware of what it is my just right state is in order to find solutions. So, in a nutshell, mental health is about being able to balance a whole range of just right states. And we are doing this all of the time as human beings. All of us are controlling to make sure our just right states are just so. And, we have an innate automatic strategy to do this. And again, there's lots of research in psychology that supports this, including Kohler's insight learning, which again, you can go and read up on. So I'm not just making this up, there is evidence for it. So we perceive how something is, we compare it to our just right state reference point, and we use our behaviour to minimise any discrepancy. Think of it as Goldilocks theory. Too much, too little, just right. So we're using our behaviour to make our experiences just the way we want them. Now, to give you some examples of how this translates to patients that we work with depression, this person came to me, their experiences had been really horribly abusive things happening to them in childhood. And the problem they had now was the image of their abuser constantly coming into their head. And I wanted to know, I asked them, does it bother you that you can't get his image out of your head? And this person interestingly said, well, yes and no. And suddenly we became aware that there were more than one just right state here that the person had. Yes, they needed to remember their abuser so that they could keep blaming them instead of themselves. But they also needed to forget the abuser in order to just move on with their life and be the person they wanted to be. Here you have two incompatible just right states, and very little awareness in this patient of those just right states. So therapy was about helping them to become aware of this and understanding that it wasn't a case of just getting rid of the image, but actually being able to manage how they felt about the image and appreciate why it was there. And there would be times where they would think about what happened to them more, and other times when they moved away from it to get on with their life. It was about balance. Now, sure, we could do this in therapy, but for some people, being able to focus on those painful experiences is too much. And having psilocybin actually helps them to be able to do that and do this work. The psilocybin is not going to be able to resolve this conflict for them, but it enables them to engage with this and think about it to develop their awareness, to do the work so that they can find some solutions. Again, this is another person who came into one of the psilocybin trials and said that they'd experienced a bereavement. Their problem was they just couldn't get over the death of their family member. Again, the underlying conflict here was they wanted to live their life, and they couldn't do that by grieving all the time, but if they didn't think about this person constantly, they were somehow being disloyal and not honouring that person. They weren't aware of that. They had no awareness of that side of the conflict. Their focus was on, I've got to move on. And so by being able to focus on this bereavement, facilitated by the psilocybin, they started to become aware of what it was they want and then work to finding a resolution. How does this change occur? Well, from a perceptual control theory point of view, it's about finding new solutions to balancing these just right states. That's when the depression starts to go away. You know, depression isn't this thing by itself. There's an underlying reason, and that's where we need to be working on to treat people. And so increased awareness actually facilitates solution generation, and people start to reorganize how they manage things, and we call it reorganization. So in psilocybin-assisted therapy, we're specifically trying to promote reorganization. It's an introspective awareness, okay? That's the mechanism of change, where new insights start to come about. And this is something that has been recognized as being important across a whole range of different therapies listed here. I just like this slide because it kind of looks a bit psychedelic and you feel very happy. It's all about awareness. So my take-home message is it's awareness, awareness, awareness all of the time. That's what we're doing. And again, this is consistent with the literature, you know, the empirical evidence that we have. Most theoretical orientations to psychotherapy actually focus on awareness. Tom Borkovic talks about this a lot in his work. A goal of most psychotherapies are to help people take a step back, distance themselves from a problem so they can get that perspective, get that awareness. And a key role of treatment is helping people develop their awareness and understanding of difficulties. So nothing is new in what I'm saying, but it's how we're going about facilitating this happening, which is new. Self-observation emerges from self-awareness. The success of interventions such as mindfulness-based cognitive therapy, CBT, which is what all our guidelines advocate nowadays, again, awareness is fundamental to those. So what is it then, from a perceptual control theory perspective, that we think needs to happen? Well, first of all, we need to help people focus on a problem and focus their attention and awareness on a problem long enough to be able to engage with the emotions associated with that. And those emotions may well be quite difficult, so this is not an easy process. That's where the psilocybin comes in, because it helps and facilitates people being able to do that. So they engage with that emotional state in a way that they haven't been able to do before. This is the process of exposure. So what you're doing is, in preparation, you're really helping them think about what the problem is, so that when they have the psilocybin in dosing, they're exposed to the emotion,